Excellent. So, welcome to our third webinar from Nobumpnocare. We are a non-profit helping people in their reproductive journey. Today, we are very lucky to have Dr. Krystal Wilkinson and Sarah-Jane.Lennie to present a webinar on transforming perinatal mental health provision in the workplace. Thank you so much for being here today. The floor is all yours.
Thank you. So I'll just introduce myself first, and then I'll hand over to SJ, and we'll bring up the presentation. My name, Dr. Krystal Wilkinson. I'm a work and employment scholar, so I work in a research centre that's doing research into work and employment. My background, I used to be a human resource management professional, and all of my research is on kind of health and well-being in the workplace, the work-life interface, but particularly issues that have not really been making it onto many workplaces' agendas. So I've done research on people who live alone and don't have children and their work-life balance. I've done research on complex fertility journeys, so fertility tests, fertility treatment, pregnancy loss. This project is around perinatal mental health, so mental health and mental illness in pregnancy and post-birth. Kind of one motivation for this was I was very, very poorly after the birth of a little boy. And when I kind of went back to work looking around, it was like, there's nobody really researching this. There's no workplaces really accommodating this in their policies and practice. So I had a chat with SJ and we did some research. So do you want to introduce yourself, SJ?
Thanks, Krystal. I'm Dr. Sarah-Jane.Lennie, but known as SJ. I'm an associate professor at Anglia Ruskin University in the UK. I'm working in a centre of excellence for equity in uniform public services, but my research focus is on the mental health and wellbeing of police officers. So, like Krystal, I have a practitioner background. I'm an ex-police officer as a detective inspector in Greater Manchester Police, and I struggled with my own mental health. I had PTSD, anxiety, and depression, which ended up me leaving my career as a police officer and led me into academia and doing more research in mental health in policing. And that is my passion, is about looking at the organisational culture and the impact that it has on individuals' mental health and well-being, and actually what we can do to improve that. And that's how me and Krystal got together. As we have a shared interest in mental health and well-being, though from slightly different angles, but very much within the organisational space. Sorry if you can hear my dog barking in the background. Right, I shall share the slides now. And then hand over to Krystal. Okay, I'll just get we're in slideshow. Can you see my slides there?
Yes.
Perfect.
Brilliant. Okay, over to you, Krystal.
Okay, I don't think, take control of these, so if we can just go to the next slide, please. A little bit of an overview of what we'll be talking about. So we'll talk about the issue, a little bit of context. We are based in the United Kingdom, so some of the statistics and stuff we'll be referring to is from the UK context. We'll talk about the issue that we were exploring, the research that we did, the key findings, some of the key recommendations for practice, and then what we've done in partnership working with particularly Greater Manchester Police, which is one of the police forces in the northwest of England. And then some kind of resources for signposting and time for questions at the end, if anyone has any. But this image is of our research team more broadly. So you can see Sarah-Jane in the middle, Dr. Keely Duddin, who's also from the Open University. She's kind of to the right of SJ. And then we've got myself in the corner and representatives from Greater Manchester Police who were sort of partnering on this project. So nice to acknowledge them, even though they're not here, very much a collaborative team effort. Next slide, please. Okay, so the problem is all around perinatal mental illness, perinatal mental health. So some of the people in the audience here may well be very familiar with perinatal mental health, but it's not a term that the average HR professional, the average work and employment person will have heard of. So we often spend a bit of time kind of defining it. But in the UK, perinatal mental illness or the perinatal period is from pregnancy through to 1 year post-birth. Although a lot of the perinatal mental health specialist services are arguing that it should be to 2 years post-birth, because a lot of mental health difficulties in this period will continue on beyond that point, and still people need quite a lot of support. So In the UK, the statistics, the official statistics that you tend to get, for example, on the National Health Service website and some of the leading charities, is that it affects mental health problems in pregnancy and post-birth, affects at least 1 in 5 women. The latest research that came out was it's more like 1 in 4, and for some areas of the UK, it's higher than that. And 1 in 10 men are also affected by perinatal mental health problems. So it's 1 in 5 women will experience some sort of mental health problem. So it could be depression in pregnancy or post-birth, it could be anxiety in pregnancy or post-birth, it could be obsessive compulsive disorder, it could be an eating disorder, it could be trauma, post-traumatic stress disorder connected to either a birth experience or having a baby that's born early or unwell, or postpartum psychosis, which is obviously a more severe medical emergency. So it's 1 in 5 women are affected by perinatal mental health issues, but there's a lot of stigma and silence around these issues. So people don't talk about it in general. We have support, for example, antenatal classes that people go to, supported by the NHS or private providers, and they don't really mention any of these things. They might mention baby blues, they might mention that you might get a bit of postnatal depression, but they don't go into the details or the specifics. Because of this, there's a lot of fear, there's a lot of confusion when people experience symptoms because they don't know what's happening to them. They are very worried that it means that they're a bad parent, that if they reach out for help, maybe their baby will get taken away. There's a lot of shame. And so the statistics from the Maternal Mental Health Alliance are that while 1 in 5 people will struggle with their mental health, 70% will downplay their symptoms when they're speaking to health professionals. And sadly, suicide remains a leading cause of maternal death post-birth in the UK. It's a working age population issue, and yet the intersection with work is largely overlooked. So we don't have a lot of research on it. We don't see it often in workplace policies around maternity, paternity, adoption, or even on mental health agendas, really. So I did a transdisciplinary kind of literature review, just looking at the intersection between the two, and identified a number of workplace factors that could exacerbate people's illnesses or hinder their recovery, or that could be more encouraging. But none of the studies were really looking at this. It was kind of factors around the impact of having parental leave or not having parental leave or having stressful jobs. There wasn't a detailed look at the varying factors in one industry. So in that review article, I said it's an agenda for research and practice. We need more research, and that's where we came to the importance of looking at this in occupational contexts that have unique challenges. So Dr. Sarah-Jane.Lennie has wrote a lot around this, and in terms of the mental health challenges that come with it, with traumatic environments and so on. She'll probably want to explain that. And our other lead researcher, Keely Duddin, has done a lot around maternity experiences. And again, in policing, maternity is sometimes frowned upon. It's a very masculine environment, and it's not always treated very well. So we'll go more into the context as we talk through the findings. So what we did in terms of the research is we had a partnership with Greater Manchester Police right at the outset. There's a police force that wants to support with this and committed to kind of working with us on the back of our findings. So at that point, we said, okay, well, let's do a research project to explore the two-directional relationship between perinatal mental health and policing employment. So how do people who are unwell or affected by perinatal mental health, how does that impact them in the workplace? But also, how do workplace factors impact on people's health trajectories? And we wanted to co-design innovations to practice, which is why having a police force on board, which was essential. So we did in-depth biographical narrative interviews, which is an interviewing style I've used quite a lot in my research, which is basically very, very open. It's just tell me your story, anything that you found to be important to you personally, as you talk through your health and your career experiences, really. And we spoke to 18 police officers or staff across 11 police forces in the UK, number of different job roles. A lot of them, their stories spanned a few job roles, a very different mental health experiences. So it was women who had experienced perinatal mental health problems, men who had experienced perinatal mental health problems, or individuals whose partner had experienced the perinatal mental health problems. That's an important perspective. As well, when I was really, really poorly, I was in hospital for a long time, and my husband had a baby, and he wasn't expected to be the primary carer, and he suddenly had a baby, and he was trying to support me. So we wanted to make it inclusive of that perspective. And then we did a focus group, a multi-stakeholder focus group. So we had perinatal mental health professionals, we had policing professionals, the research team, we all got together and kind of talked through the findings from the interviews and what that might mean for policy and practice, enablers, barriers, and so on. And at the moment, we're trialling interventions. Next slide. I think it's over to you, Sarah-Jane.
Yes, it's over to me now. Thanks, Krystal. So looking at what the findings were, the first one is, I would say, probably typical of the population around awareness around perinatal mental illness, about what those symptoms can be, different types of illnesses, as Krystal's talked about, and who they can affect as well. And just some of the quotes here show that people just don't realise, even when they're going through it, exactly what is happening for them. So the quote here, "I never thought I was ill. I just thought I was a horrible person who wasn't cut out to be a mother." And I think that kind of really echoes kind of the play of this narrative around the perfect mother. And actually, there's no recognition of how difficult it can be. And the comparison that people are making between their own experience and what's portrayed perhaps on social media. And then men, just not publicised about, how that men also experience perinatal mental illness. So the gentleman here saying, "I was just denying it. I was just saying this isn't a thing. Men don't suffer with this," which is actually, as we all know, just isn't true, but people just aren't aware. And the final quote here, "I'd never heard of intrusive thoughts before. Everyone, when they talk about maternal mental health, they just talk about baby blues and feeling depressed. And I didn't feel depressed." And I think that's really important, that actually we talked about symptoms and people being aware of things. The more that people can be aware of what it is that they're experiencing, the less that they're going to blame themselves and have that sense of shame. But also actually, move into a help-seeking move. What we did also find was that not that surprisingly, was that actually operational factors of policing, the job itself, the experiences that parents have through their career prior to becoming a parent and post, actually affect the way that their mental health is affected by the job and how that influences beyond what you might expect in other occupations. So this would include being exposed to traumatic events, particularly ones involving children. So the quote that we've got here, "I was having flashbacks to what his sudden unexplained death of a child." So actually attending events which involve children actually really influences and gives a narrative to parents that these things happen more often than perhaps somebody else might think, and can make people more anxious that their baby's going to die as well, and often leads to behaviours where people, let's say here, sleeping on the floor, having that constant anxiety. So those experiences, and they can be many experiences, not just in relation to babies. I know from my own research looking at mental health that it can be any experiences where there's been trauma, where there's been threats to life. These are experiences that typically a new parent wouldn't actually have, but with police officers, they do have them, they do experience them, they do see them, and this can fuel their worries and the concerns about what could happen to their child. There was also, we found, concerns about seeking mental health support. And this goes throughout policing. There's a great stigma around mental health, and therefore people won't access help because they're concerned about how that will impact their work and their careers. So if it does go on record that they've had a mental illness or requested support with mental health, this can actually preclude them later down the line from actually getting licensed to go. So perhaps they want to go into firearms. There's certainly in my own research, we found that people that have wanted to go in firearms, women that have gone to firearms, if they've had a perinatal mental illness, that stays with them and they can be precluded for going those jobs. I know one lady that talked about their son being 18, but because she had suffered perinatal mental illness when he was young, she was prevented from actually applying for a firearms. And the same with driving. People are concerned that they might not be able to be, go into a response vehicle, police vehicle. They may use their police driving license, so that it won't be operational within the service. And then there's the other aspect is the police officers deal with people that are struggling with mental health themselves, and often they end up taking people to mental health clinics, and they're concerned about bumping into people, whether that be clients, members of the public, or actually mental health professionals themselves, who they see as part of their work. they don't want to actually expose themselves to those people, particularly if they're trying not to let the job know that they're struggling with their mental health. So it's really difficult for people to actually help seek because of the stigma in the organisation, but also to help seek outside of the organisation as well. And then there's the punitive responses that that occur when somebody does disclose that they are pregnant, and it's very similar to the way that they treat people who disclose that they have mental ill health. And it's very clear through this research and also some other research I did on police families that that having a family, having children isn't welcome in policing. And from the very moment that a woman will disclose that she's pregnant, she starts to begin to feel like she's a second-class citizen. So this quote here is explaining how as soon as a woman discloses that she's pregnant, that she's removed from her operational role. She's also removed from her team and put into a different department. I'll read the quote and explain it a little bit more. They never took me into consideration. It was, you're pregnant. You're now restricted. You're not a resource to us, and we're just going to shove you downstairs. And the downstairs department was classed as the lame and idle department. So my work colleagues were taking the mick out of me going. So it's really stigmatized, this whole sentence, because the lame and idle department is typically a department that looks in public protection and child protection as well, and domestic abuse. It's where people typically don't go to that many operational response jobs. So there's an ability to find a desk job, which is where the police are perceiving the reduced risk. But it's also where people that have got a physical disability or illness, so they've been injured on duty, or they have a mental illness, are also placed. So therefore, hence the stigma attached to this department. And when women are placed in these departments, they're stigmatized as well, even though they're down there because they're pregnant. And it also removes their identity as an effective police officer by being told that they are no longer effective in their role. They're also isolated as well, so when they're taken away from their teams. And yeah, it's a culture that's very hostile to mental illness. As this quote says, it's a thing that just can't be talked about in the policing organisation because it's effectively going to potentially stop you from moving through any career structure if you've almost got a black dot against you for having some sort of mental health issue. It's what we call in policing, it's career limiting if you disclose that you have any sort of mental health issue, which precludes people from disclosing and help seeking, as you can imagine, and particularly difficult for people that are already being stigmatized, but actually just wanting to have a family. And then we found that there was a real lack of line management and continuity, which begins when women are pregnant and obviously moved away from their teams, they've moved away from their line manager as well. And there's a lack of contact during leave, probably a lot to do with the fact that there's that lack of relationship that's built up with a new line manager because they're not with them for long. And we found also there's a real lack of flexibility and support in returning to the work. One of the greatest anxieties that people were describing was actually trying to get a flexible working pattern so that they could look after their new child and return to work. And there was nothing coming back from the organisation to support them with this. The closer they got to returning to work, the more anxious they became. They didn't see any options presented to them. And this is something that, at the moment in policing, we have a real retention issue within the organisation. And this is one of the contributing factors. So what the quote that we've got here, I tried to sort of come up with all these alternative arrangements I could do with my employees in terms of flexible working and things like that. And like literally everything was not met because nothing ever met the business needs. And the other thing I should say about that is, the expectation is on the woman typically to actually find the right pattern for the organisation. And this was particularly exacerbated if both parents were in the organisation and both required a flexible working option, but they couldn't be discussed in the same meeting. So if the partner of the birthing parent was in the police service, it wasn't like the two flexible working patterns were ever considered together. So that became very difficult and very complicated for people to navigate at a time when they really needed support and felt vulnerable anyway. What we also know is that this has a negative impact on the workplace due to the illness that people are experiencing and how it's managed in the workplace, whether they return to work or not, or how they return to work and whether they go off sick. And as Krystal says, it's not just the immediate return to work, but it can go on for up to 2 years. And the quote we have here, this bucket was getting fuller and fuller and fuller. And one shift, a bad shift, I had one night, just took me over the edge. It wasn't even anything major. It was just everything sort of culminating together in like just job after job, no support from management. It was a fatal accident involving a young girl. And after that, I went to the GP and he basically signed me off with chronic stress. And we know that these things can be prevented just by allowing people to help seek. But actually, because people aren't being supported in the workplace, they're being exposed to different jobs and they have no way of processing it. This is having a real impact. I know from my own research that there are people that work in child protection, for example. There's one lady that was saying she returned to work and she was telling me how she felt very different about the risks that she was willing to take, and actually how working with children was impacting her differently. And what she said to me was, nobody prepared me for this. Nobody prepared me for how different I would feel about doing this job. And I think that's really important, because there's a change of identity, there's a change of priority, there's a change of attitude towards risk when you know that you've got a young family that you want to go home to. So there are opportunities for workplace factors to improve. We can do better around how we support new parents, both men and women and non-birthing partners, in actually returning to work, the way that they're returned to work and the way that they're supported. We can use those strong team relationships that you do have within the police and make sure that that sense of identity as a police officer can support them. But at the moment, that's often eroded and there's a lack of support, which means that often we see women leave the police and men compromise their careers. So what did we recommend? Over to Krystal.
Thank you. Sorry, I got kicked out of my screen froze halfway through, but I'm back. If I go again, SJ, just please do take over. So some of the recommendations that we've highlighted for sort of all employers, and we'll go on to talk a bit more about how this is gaining traction beyond just policing. It's just, first of all, awareness raising around perinatal mental health. So make it something that is not completely alien to conversations in the workplace, and even to the fact of if somebody types postnatal depression into a company's intranet, they get a hit. It's not just kind of like just deathly silent. We have Maternal Mental Health Awareness Week here in the UK, and there's World Mental Health Awareness Day. So you can draw attention to this issue in events like that, or you could do blogs on your internet or whatever. Signposting to internal and external support, so explicitly connecting your maternity, paternity, adoption provisions to the fact that you probably might have existing mental health provisions in the organisation. People might not be aware of them. During their maternity leave, it might be the first time they've ever had a mental health issue. They don't know what's there. Including mental health, perinatal mental illness, specifically in your maternity, your paternity, your adoption, other policies, fertility treatment policies, pregnancy loss policies. Anything where somebody might be trying to find information around this issue and their rights in the workplace, reference the fact that this is really common to have mental health issues at this time, to not always know what that looks like, and some signposting. And that can be signposting to specific toolkits and so on, but also to charities, like some of those external supports. We've got some really good charity provisions in the UK. So signposting to those. On audit of your policies and your processes to actually identify any opportunities to better identify perinatal mental health issues. So in the UK, we have, under the health and safety regulations, requirements to do a risk assessment, an individual risk assessment with somebody when they are pregnant and when they declare their pregnancy. And again, there are some requirements around the return to work if a lady is still breastfeeding or it's within 6 months of having given birth. So there's an opportunity there to ask some questions about mental health, that we should be having wellbeing meetings routinely through maternity and paternity journeys and adoption journeys. Rather than just explaining somebody's entitlements to time off and pay, actually check in on their well-being. And in the UK, again, we have something called keeping in touch days, which are days where when you're on parental leave. So parental leave usually is extended in the UK more than in some countries in the US. So because somebody might be out of the workplace for 6 months, 9 months, 12 months, we have these days where you're entitled to come in and work and get paid for your work without it interrupting your maternity pay. But again, within those, in the policing research, people will be just being given a radio and handed out, go and do your day, go and do your job, go out in a response car for 8 hours or whatever, or being called in to use a kit day because there was a shortage of staff or something. It's about being a bit more intentional, that if you're having contact during your maternity leave and you're coming into the workplace, that's about making sure that you're aware of training and things like that, and having, again, wellbeing conversations. Hugely important is education for managers. Line managers are often at the front line of supporting somebody or potentially identifying if somebody is not well. So making sure that they are aware this is something to be looking out for, and how to signpost people and support people. And special attention to that return to work part from parental leave, and consideration for how you handle flexible working requests. And are you giving it due thought, or is it just that, oh, that's something that's too hard to accommodate, so let's just say no? Which obviously can really set somebody back with their mental health journey. Next slide, please. So we worked in partnership with Greater Manchester Police, including helping them with internal awareness raising. But the main thing that we did is we devised a new toolkit for supervisors that gave them information around the different perinatal mental health conditions, some symptoms, how it might manifest, the fact that people might not know when they're experiencing a mental health problem at this time, the fact that they might be scared to talk about it. So we explained all of that with clear signposting for more information. We designed these flowcharts through maternity and paternity journeys to explain the different parts, at the part where somebody informs you of the pregnancy, going through risk assessments, going through planning for leave, contact during leave, and that return to work, and ongoing, because we know these issues can persist for some time, in terms of how managers can approach these things, what they can do, how they can support. We also supported a revision to the maternity risk assessment process to specifically ask about mental health. And what we did is we used NICE guidelines, which is the National Institute for Clinical Excellence. So there's some questions that are designed for health professionals who are not perinatal psychologists, but they're health professionals who might have contact with somebody during the perinatal period, that can get at possible signs of depression or anxiety. So it's like midwives and health visitors. There's a series of questions. So we're trialling at the moment whether line managers asking those sort of questions in check-ins could potentially help an individual and their manager understand when somebody might be struggling, an ongoing evaluation. I don't know whether you want to come in on that point.
I might as well, actually. Yeah, thanks, Krystal. I'll hand back over to you. The evaluation is kind of like phase 2 of the project. So as an ex-officer myself, and probably for a lot of organisations, the research is great, the toolkit that I'm really proud of, and the work that Krystal's done around this. But what's really important for me is that we make sure that this is actually making a difference to the people that we intend it to work for and to support. So what I'm doing, working with 3 police forces across the UK, I'm doing an evaluation, which is more of a understanding what scaffolding is required within the organisation to actually make sure that the toolkit is used, and is used in a way by supervisors that actually does provide support, that it is getting to men and women who are new and expectant parents, and that they are feeling supported, and actually that helps their journey and prevents perimental mental ill health, and actually, you know, improves flexibility within work, access back to work, and their support. So that's something that's just at the beginning at the moment, and I'm really excited to be part of that, because I'm hoping that will be where the real difference really kicks in. But yeah, over to you, Krystal, and I'll flip slides.
That's great, thank you. Yeah, so just the fact that, you know, we are moving beyond just Greater Manchester Police and beyond even policing. So the research summary and the toolkits have been signposted on through various other organisations. So obviously this is yourself with the Nobumpnocare. I think you've been sharing some of our stuff. Blue Lights Together, which is a UK-based service that brings all the kind of frontline service personnel together. So it's fire, it's police, it's I think the NHS may be in there as well, and other groups. So again, other professions where there might be some similarity there with some of the concerns, for example, with ambulance service and NHS professional, this idea that I can't really present mental health because it might.
Oh, have we lost Krystal? I think what she was saying there, where there's a similarity where there's this mental health stigma, or asking for help might actually impact their career. There's also the parent gap. Krystal's really led on this new employer offering for the Maternal Mental Health Alliance and PANDA. So really good work from Krystal in her area around the charities. My old university, the Open University, Keely's been working with the Momentum campaign that they've been working with, and this has been added in their employer and employee toolkits, which focus on return to work after maternity leave. We've presented to the College of Policing, which is the national institution in the UK for policing, their occupational health network, so a national occupational health network, the employers in social housing and healthcare and early year sectors are all utilising the resources and the toolkits. We're speaking at national conferences on women's health network and mental health at work and the Association for Women in Policing. Krystal presented at the roundtable in the House of Lords on perinatal mental health in the workplace. And also we've been invited to present at the International Association of Women in Police Training Conference in Glasgow this year, actually. I think it's September. So yes, thank you very much for listening. We've got some more resources here. So there's links to the research summary here and the Supervisor toolkit. If anybody wants, anybody wants any of these or the copy of the slides, please just get in touch with Susie. She'll send them on, or in fact, on the next slide, we have our email addresses, and just get in contact, please do, because we'll happily have a chat with you, share our resources and anything else that we can help with. That's it. Thank you very much. I'll get rid of my slides.
Apologies for my awful internet this afternoon. So glad you're there, SJ, to carry on when I just disappeared. I was talking and it's like...
Sorry, the connection failed you. But this is fantastic, and I will put under the YouTube presentation the slide with the resources and your emails, so that people can contact you and can also access the resources if they need to. Thank you. I mean, we really needed presentations like this in any field. I mean, listening to what is happening in police, it makes me think, okay, and who knows about, I don't know, nurses or teachers.
Paramedics.
Yeah, I mean,
very similar.
We really need to do a microscopic search of, just looking at our life and how poorly perinatal situations, I would say, are treated, perinatal life. I don't know how to call it, because I have the feeling that even the words are not enough here. We don't have enough words to speak precisely about each case. Anyway, thank you. It was fantastic. Unfortunately, we lost our people. I see that there's someone on YouTube if they want to ask questions. So there's a little bit of delay, 15 seconds delay.
Yes, it's fine.
While I don't know, I was thinking, but clearly the answer is no here. Why don't they introduce as any nursery in the
police? Oh, so yeah, so I've raised this, I've recommended. So I also did a piece of research looking at the well-being and support needs of police families. And one of the things that we talked about was what they really wanted was a nursery, because as you can imagine, because the shift work and the unreliability of finish times because of the nature of the work, it's very difficult to get nursery care, because typically shifts start earlier than nurseries open, and they're not willing to stay late and, you know, hang on for those police officers that may be late because they've been held on because there's been a major incident that's occurred. So yeah, it's really needed, but it's something, certainly in the UK, that police forces just aren't capable of delivering. What's really interesting is in one of the focus groups, when I did that piece of research, there was a lady that used to be a mental health nurse in Broadmoor Prison, which is a high category prison within the UK that has psychiatric inmates, prisoners. And they had a nursery for the staff within that. So I'm like, if they can do it there of all places, you know, why can't we do it in the police? But I think it's so difficult in terms of estates, finances, you know, having staff, you know, nursery staff on site within such, you know, a risky area. But yeah, absolutely, I agree with you.
Crazy. And another, but here it's more, sorry, it's more of a comment. Sorry, here it's not easy. Another strange thing I noticed is that when it's about perinatal mental health, We don't have categories yet. I mean, I give you the example. I was writing a piece, a very basic piece on matrescence and feeling touched out for an important, psychological journal. Don't mention the name, but and they wouldn't give me the category motherhood, perinatal care,
Yes.
maternity.
Yes.
I mean, even in psychology, we still have to catch up with the categories that are loyal to what we are experiencing. It's just baby blues or depression. And
Yes,
it's not
exactly.
even, it's
And that's yeah, absolutely. I'm sorry, Krystal picked this up, but unless we are explicitly referring to things and putting it into the social conscience, people aren't going to be aware. And also, actually having those categories, being labelled, having it present is validating for people going through the experience, and making it a concern of consideration, and that what they're experiencing can be talked about and should be supported. And Krystal will go on much more about this, but yeah, you're absolutely right.
Well, I think you said it. You said it all there. Yeah, if we don't have a name for something, we can't easily talk about it, and people feel alienated. They feel stigmatized because, as that person said before, I've heard of postnatal depression. People talk about postnatal depression, didn't feel depressed. So people don't make the connection that it's actually an illness because of some of the thoughts, and that's a barrier to getting help. Or even when we tried with these toolkits, we named it a perinatal mental health supervisor toolkit, and people were like, "A what now?" So we had to change it to an expectant and new parent supervisor toolkit, mental health. But it's tricky.
It is, yeah, it is very tricky. And it makes it's isolating for people, which is, and as you say, people go on to feel so much shame that like they're a bad person. It's like, no, you're poorly, you need support.
The quotes you cited were really touching, because sometimes it might be something much lighter than they expect. For example, the problem of feeling touched out. Okay, you just need to refocus, regroup, and care for yourself. But while you are experiencing it, it feels like, oh my God, now I'm such a bad person. I'm not cut for being a mother. I'm a monster. And, it becomes bigger exactly because you don't have sometimes knowledge, words.
Yeah. I've seen quite a lot on maternal rage.
Yeah.
There's this anger, and it's like, again, I'm a monster. I shouldn't. How could I feel this? And it's because we don't talk about it and people don't know.
Yeah, that's true.
And the intrusive thoughts piece, we've certainly touched on that can be really, really scary for people.
Yeah, the intrusive.
Absolutely.
No, it was a fantastic presentation. I hope we'll be able to circulate this video as much as we can.
Will you let us know when it's on? So does it get recorded straight away on YouTube?
Yeah,
because I'd love to get this.
I will, as we are talking, we are already recording, and I will share the link with you, or you can already go to my channel and you find it already there.
I do look for it. Fantastic.
Well, I don't see any question. I don't know if you have any final remark you want to share with us.
No, for me, thank you so much for just hosting us and hearing about our research. And for anybody out there, I hope it's helped in some way. And please get in touch if you have any questions or want the resources.
Yeah, and I don't know with the countries that people might be listening from, but see if anyone is making these conversations about the connection between perinatal mental health and work. Whether it be some of the charities might want to do a campaign, or a particular workplace might want to do something and be a front runner. Because certainly in the UK there was just very little, that we could find until we started these conversations.
That's a good point. Yeah, let's circulate knowledge.
Start campaigning.
Yes. Thank you so much. I wish you a wonderful weekend, and let's keep in touch.
Thank you, and you. Thanks very much.
And next meeting is going to be on pregnancy trauma, again Friday, again same time, just for the people on YouTube.